All right, folks, we're going to be beginning here. Good afternoon, everybody. I'm Michael Rhea. I'm one of the second-year pulmonary critical care fellows, and this afternoon I'll be discussing allergic bronchopulmonary aspergillosis. So I'll start by discussing a little bit about aspergillus. This is a spore-forming mold for which there are over 150 identified species. And aspergillus is ubiquitous in the environment. It's found everywhere, both indoors and outdoors, in the soil, compost, grass, damp basements. And because of that, inhalation of aspergillus spores is pretty much unavoidable. And unfortunately for us, it grows pretty well at 37 to 40 degrees Celsius, which is the human body temperature, and it grows very well in our airways. So aspergillus can cause a wide spectrum of pulmonary disease when patients inhale aspergillus spores. In a normal host, there's generally no sequelae of inhaling these. In patients with cavitary lung disease, they can have an aspergilloma form, which can cause anything from asymptomatic disease to massive hemoptysis. In patients with chronic lung diseases or mild immunocompromise, they can cause a chronic necrotizing aspergillosis, which is like a more subacute to chronic form of invasive pulmonary aspergillosis, which is seen in patients who are more severely immunocompromised. And then what I'll be discussing today is allergic bronchopulmonary aspergillosis, which typically occurs in patients with asthma, cystic fibrosis, and atopic conditions. The pathogenesis of this disease and what occurs after inhalation of the aspergillus spores is due to colonization in susceptible hosts. Remember, this is not invasion of the lung parenchyma, but colonization of the airways. And in certain patients, this leads to an allergic and immune-mediated lung disease. So this is a schematic of the airway inflammation that occurs in a result of these fungal allergens. So your normal airway epithelial cells have an exposure to these fungal allergens that are sitting in the airway. And in certain susceptible hosts, they have a dysregulated immune response that favors a Th2 response, leading to production of IL-5, IL-4, eosinophilia, and IgE production, which over time leads to increased airway mucus production, bronchoconstriction, inflammation, and over time bronchiectasis and fibrosis, with resulting decline in lung function. The pathology that occurs as a result of this inflammation, if you see, there's a normal bronchiole over on the right side of the screen, but over on the left, you have these large dilated bronchiectatic airways that are filled with mucus and mucus plugging. That mucus tends to have a significant eosinophilic inflammatory infiltrate. And certain forms, such as the Charcot-Leyden crystal, are evidence of that eosinophilic inflammation. This is a protein produced by eosinophils. Some cases you may have bronchocentric granulomas, which in this case is basically obscuring the entire airway. But in other patients, it may simply sort of line the walls of the airway in response to the inflammation that is going on against the aspergillus proteins. Advance on my end. No.
Are the slides advancing now for those that are watching?
We can sort of just recap here quickly. This is the immune response. Immune response that occurs to the fungal allergens in the airway, leading to the Th2 response that leads to IL-4, 5, eosinophilia, and IgE production, which causes the change in lung function over time as a result of bronchiectasis and fibrosis. And we just went through a couple pathology slides that I think weren't showing up on everyone's screen. So this one here is just showing bronchiectatic airway filled with mucus. I think it's still not working. Sorry, we're going to pause here for a second.
Are the slides advancing now? Slides change. Okay, sorry.
That's okay. So it looks like they're back working now, but if someone can send a message if they're not. We're just going through some of the pathology slides. This one's showing a bronchiectatic airway with mucus impaction. The slide here, the mucus itself is generally sort of lined with this eosinophilic infiltrate. And you may see Charcot-Leyden crystals evident of eosinophilic proteins and eosinophilic inflammation. This slide here shows bronchocentric granulomatosis. In this case, the granuloma is essentially obscuring the entire airway, though it may also occur in the walls of the airways in reaction to the fungal allergens. And this is just a pathology slide of fungal elements, which are generally seen in this case within the airway mucus. And to remember that this is not an invasive disease, it's simply within the airway itself and the immune response to it. So the susceptible hosts that get ABPA tend to have atopy and inflammation, which we generally think of as being an inherited sort of hyperimmune response. Though interestingly, this is not reflective in disease prevalence, and this tends to not have a familial prevalence. Patients often have coexisting atopic conditions such as dermatitis and sinusitis. The patients that this most often occurs in are those with asthma. It occurs in 1 to 2% of asthmatics, and patients with cystic fibrosis, depending on which epidemiologic study you look at, maybe anywhere from 2 to 15% of patients with CF. There are also reports of patients with COPD, previous tuberculosis, and those with sarcoidosis treated with infliximab who have a similar syndrome. ABP and asthma has an incompletely understood relationship, whereas about 25% of patients, of general asthma patients, are sensitized to ABPA. Only around 1 to 2% actually are sensitized to Aspergillus fumigatus. Only 1 to 2% get ABPA, and it's not entirely clear why certain patients get it and others don't. Patients with asthma who get ABPA are typically adults aged 20 to 40, and it occurs many years after an initial asthma diagnosis. Many of them have CFTR mutations. They're heterozygous for these mutations, and that speaks to the importance of the properties of mucus and inability to clear the aspergillus from the airways that plays a role in the pathogenesis. And as I mentioned on the last slide, the familial occurrence seems to be quite rare in this disease. Patients with cystic fibrosis have a more typical profile when they get ABPA. They typically are male and adolescent and overall have a lower lung function. They often have a history of wheezing or asthma and have recurrent infections or colonization with Pseudomonas. The majority of these patients have atopy. And as I mentioned previously about the CFTR mutation seen in patients with asthma, ABPA and cystic fibrosis is most likely a result of the impaired airway clearance associated with this condition. Clinical features of ABPA are typically symptoms of the underlying disease, and it may be difficult to differentiate or pick up from the underlying disease, such as cough, wheezing, or recurrent exacerbations. One typical reported symptom of patients is that they will have an increase in sputum production or new sputum production that they didn't have previously, and may complain of thick sputum or mucus plugging that is tan or brown black that they're coughing up. Patients will occasionally have hemoptysis that is generally not massive, and they often also have constitutional symptoms such as fever and malaise. Laboratory studies that point towards a diagnosis of ABPA, the typical one will be a total serum IgE that is greater than 1,000. Other findings include elevated serum Aspergillus IgG antibodies or elevated precipitating antibodies to Aspergillus. Elevated eosinophils, generally greater than 500. And interestingly, 2/3 of patients with ABPA will have a sputum culture that does readily grow Aspergillus. However, this is not a diagnostic criteria, and the presence of Aspergillus in a sputum culture is not really predictive for or against ABPA. There are many patients with asthma who will grow Aspergillus in their sputum who don't have ABPA, and likewise, this third of patients with ABPA may not grow Aspergillus in their sputum. Pulmonary function tests in this condition often show airflow obstruction, which early on in the disease or with mild disease is reversible or partially reversible. And then over time with progressive disease, patients may develop fixed obstruction and reduced lung volumes. Likewise, they can develop reduced diffusing capacity, particularly during exacerbations or with end-stage fibrotic disease. The radiographic features are important to highlight here. This has been described as a picturesque disease because of the very typical imaging findings that we'll see in ABPA. And this was a really nice article by Dr. Agarwal, who is one of the leading researchers on this topic. It's a pictorial essay of ABPA that was published in the Indian Journal of Radiology and Imaging. These are serial radiographs from a patient over a 3-year period from 2004 to 2007, highlighting one feature of ABPA, which is these fleeting opacities. So you can see over time, the patient has differing opacities in different areas of the lungs, which they may be, treated for pneumonia, their opacity and receive steroids at that time, and their opacity may resolve, but it could come back several months later. In this case here, it was actually a patient who was being treated for suspected tuberculosis over time and did not resolve and continued to have these fleeting opacifications on the X-ray. Other radiographic features can include atelectasis or even lobar collapse. Like in this patient here on the left side of the screen, they've had left upper lobe collapse, which resolved with a course of steroids. Certain radiographic features of mucus impaction, like the Y-shaped shadow that you can see right here. This is an airway that's impacted with mucus. Or a more dramatic presentation would be the finger and glove opacity. So these are bronchiectatic airways with mucus impaction. And you can see that kind of glove sign on the right side of the screen outlined there. Other features of bronchiectasis and airway dilation and wall thickening include the tram line or tram track sign. This is a more subtle feature. I'm not sure it's showing up well on the screen, but sort of on both sides here, you can see some tram tracking. And then the ring shadows are a little bit more obvious, and this is a feature of central bronchiectasis that is a typical feature of ABPA. This X-ray would be from a more advanced presentation of ABPA. On the left side, you can see features of dilated airways with bronchiectasis, as well as reticulation and end-stage fibrotic disease. And this patient presented with a large right-sided pneumothorax. There are typical CT findings of this disease, such as central bronchiectasis, which can be seen here. The definition of central, there are some differing opinions on this. It's generally regarded as the inner 2/3 from the hilum to the chest wall, though some may call it the inner 1/2 from the hilum to the chest wall. And bronchiectasis can come in many forms. Cylindrical bronchiectasis has this typical signet ring appearance that you can see on the screen below. This irregular or varicose bronchiectasis can be another presentation. And the patient on the far right has pretty advanced cystic bronchiectasis. Other features that this CT highlights are mosaic attenuation as a result of small airways disease, as a result of the bronchiectasis over time and air trapping. And then this arrow over on the left points to tree and bud nodularity, which can also be seen in ABPA. One feature of ABPA is called high attenuation mucus plugging. This is considered to be pathognomonic of the disease. It occurs when the attenuation and density of a mucus plug is greater than the ipsilateral paraspinal muscle. It's not seen in all that many patients with ABPA. It's about 20% or less, but when it is found, it is considered pathognomonic of the disease. Now we'll talk a little bit about the diagnosis of the disease. We've talked about some of the features, laboratory findings, and imaging findings, but how do we pin down this diagnosis? The first step is having a high clinical suspicion. This is a disease that there's commonly a significant delay. Patients are treated for recurrent pneumonias or just advanced presentations of their underlying asthma or CF until it's picked up that they have ABPA. The challenge with diagnosis is that there's no individual test that establishes it, and there is no clearly agreed upon diagnostic criteria that's been prospectively evaluated. But I will discuss the most current, well-accepted criteria. So the initial reporting of ABPA was in 1952 by Dr. Hinson. This was a case series of 8 patients with Aspergillus-related pulmonary disease, 3 of whom had a new syndrome that was later described as ABPA based on the clinical features of this disease. The first diagnostic criteria were presented 25 years later by Rosenberg and Patterson in 1977. And there have been a few different iterations of diagnostic criteria over time, but the most current and probably most well accepted at this time were by Dr. Agrawal, working for the International Society for Human and Animal Mycology Working Group. And I'll describe this diagnostic criteria right here. So the patients must have one predisposing condition, either asthma or cystic fibrosis, though they do note in this criteria that some patients, as I mentioned earlier, with COPD, previous tuberculosis, or in certain cases of sarcoidosis, have been found to have this syndrome. There are obligatory criteria that must be present, either having a serum IgE level to Aspergillus fumigatus or an Aspergillus skin test positivity. These are one of the obligatory criteria, as well as having an elevated IgE concentration that's typically greater than 1,000. And then the other criteria, of which 2 must be present. These are either precipitating serum antibodies or IgG antibodies to Aspergillus, radiographic opacities that are consistent with ABPA, and a total eosinophil count of greater than 500 in glucocorticoid naive patients. One differential diagnosis that I do want to point out, I won't go through all of these, but to mention allergic bronchopulmonary mycosis. This is essentially identical to ABPA, but it's caused by a different fungus. So there's 26 different fungi that have been documented to cause a similar syndrome to ABPA. So they would meet all of the other diagnostic criteria that I just mentioned, except they don't have the hypersensitivity and IgE reactions to Aspergillus fumigatus, but they may have it to different forms of Aspergillus or Alternaria or Candida or several other different fungi. The natural history and staging of the disease includes 6 different stages. So stage 1 is considered to be the acute stage. This is new active ABPA with typical features that include a markedly elevated IgE as well as radiographic infiltrates. Patients who are said to be in remission, both clinically and serologically, a key feature of this is that they have no infiltrate while being off of steroids for at least 6 months. Stage 3 includes recurrent exacerbations or recurrent active ABPA, which is essentially like stage 1 in a patient who had either achieved remission or improvement with a new marked increase in serum IgE as well as recurrent or new radiographic infiltrates. Stage 4 is corticosteroid-dependent asthma, which many patients end up falling into. And in these patients, new infiltrates may occur, especially when prednisone doses are tapered down. And often these patients require very high doses of steroids, at least 30 to 40 milligrams a day to achieve control of their disease. And then stage 5 is end-stage fibrocavitary disease, secondary to untreated ABPA. And these patients have fibrotic, bullous, or cavitary lesions. It's important to note that the progression through these stages is not linear. There are many patients who will go from stage 1 directly to corticosteroid-dependent asthma and end-stage fibrotic disease. There are certain patients like that who just don't achieve remission or don't improve enough to actually even have sort of recurrent exacerbations. They just progress to stage 4 and 5. And then there is also a stage 0 or ABPS, which means that the patient has a serologic diagnosis of ABPA, but does not meet the diagnosis in terms of clinical and radiographic features. And there is still some debate on whether or not it is advised to treat patients with ABPA stage 0 to prevent progression to further stages, or whether or not just controlling their underlying disease is the preferred approach. So treatment of ABPA. The goals of treatment include prompt identification and treatment of exacerbations to minimize that ongoing airway inflammatory response, to minimize bronchiectasis and fibrosis formation over time. Managing the underlying disease, which is typically asthma and cystic fibrosis, and then identifying environmental sources as a way to help sort of control the allergen burden. So the main target of therapy is going to be just sort of generally targeting the immune and inflammatory response with corticosteroids. And these are really considered to be the cornerstone of therapy. So the guidelines from the American Thoracic Society recommend that patients with ABPA be started on a dose of steroids of at least 0.5 milligrams per kilograms per day and tapered as indicated by symptom improvement. I will note though that there are also other markers that need to be followed other than symptoms, including IgE, PFTs, and serial imaging. It's generally recommended that these patients are followed as frequently as every 6 to 8 weeks. And to note that just because a patient is not having symptoms does not mean that they have stability. They can have worsening of their PFTs, elevated IgE, worsening radiographic findings, and may need to continue to have either escalating or recurrent doses of steroids, despite the fact that symptomatically they feel okay. And for acute exacerbations, the typical dose is 0.5 to 1 milligrams per kilogram per day for a week or two, followed by every other day dosing of 0.5 milligrams per kilogram for around 3 months. Despite these recommendations, there is fairly limited supporting evidence overall, and there are no placebo-controlled trials. The bulk of this evidence comes from 2 case series, the first of which by Patterson in 1986, was of 84 patients who were observed over a 3.7-year average period. And the protocol for steroid dosing in this case was 0.5 milligrams per kilogram for 2 weeks, then alternating days for 3 months, as per the previous recommendations that I just noted. And they were able to discontinue prednisone unless it was needed to control their asthma. And in this case series of 84 patients, which was predominantly patients in stage 2 to 4 ABPA, none of them progressed to fibrotic or stage 5 lung disease. The next case series was by Dr. Agarwal in 2006. This was of 126 patients. They used a little bit higher dosing of steroids and a little bit longer of a protocol. So starting with 0.75 milligrams per kilogram for 6 weeks, then down to 0.5 milligram per kilogram for 6 weeks, and then tapered by 5 milligrams every 6 weeks for a treatment therapy duration of about 6 to 12 months, as opposed to the 3 months seen in the previous series. And in this case series, all patients achieved remission by 6 weeks as defined by clearing their radiographic findings and a reduction in IgE by more than 35%, though there was a relapse rate of around 20%, and 13.5% of these patients ended up being steroid dependent during the duration of this study. In order to determine which regimen of steroids was best, Dr. Agrawal performed a randomized controlled trial of 92 patients, comparing the two dosing strategies used in these case series. So the lower dose and shorter duration in the Patterson case series from 1986, compared to the higher dose, longer duration from Dr. Agrawal's other study in 2006. And overall, their primary outcomes were exacerbations at 1 year and glucocorticoid dependence at 2 years. There was a trend overall to benefit in the high-dose steroid group, however, neither of these met statistical significance. In terms of response to treatment at 6 weeks and percent of IgE decline at 6 weeks, there was significant benefit in the higher dose steroid group. However, as mentioned above, this was not a long-lasting benefit over time. In the higher dose steroid group was associated with, as we would expect, more complications of long-term steroids, including Cushingoid habitus, striae, and weight gain. So overall, the authors of this study concluded that there was really no difference between the low dose shorter course compared to the higher dose longer course, and there was greater adverse events of a greater steroid burden over time. And these are consistent with the current recommendations by the ATS. Another target of therapy is reducing the allergen burden that creates this hypersensitivity response by using antifungals. These are considered currently to be an adjunct therapy. The role of antifungals isn't clearly defined at this time. The American Thoracic Society, the most recent recommendations in 2011, did not specifically provide a recommendation on this, but stated that itraconazole has been used as a steroid-sparing agent. The IDSA does recommend treating symptomatic asthmatics who have bronchiectasis or mucoid impaction despite being on steroids and giving them itraconazole, or in cystic fibrosis patients who frequently exacerbate or have a reduction in FE, or have a progressively reducing FEV1. The major two trials for antifungals are looking at itraconazole in patients with ABPA who are predominantly already on steroids. The first one was in 2000, and this was a randomized double-blind placebo-controlled trial of 55 patients with ABPA on steroids, comparing a total daily dose of 400 milligrams of itraconazole versus placebo for 16 weeks. Their primary outcome was a response to treatment, which they defined as a decrease in steroids by more than 50%, as well as a decrease in IgE by more than 25%, and at least one of the following, being an increase in exercise tolerance by more than 25%, an improvement in one of the following 5 PFT values by 25%, or resolution or absence of infiltrates on therapy. And what they found that meeting their definition of response to therapy, 46% of patients in the itraconazole group met this endpoint versus only 19% in the placebo group, and this reached statistical significance. The other major study in this area was done in 2003 by Work, and this was a randomized double-blind placebo-controlled trial of 29 patients, again with a total daily dose of 400 milligrams of itraconazole versus placebo for a 16-week period. Their primary outcome in this study was sputum eosinophils, and found a significant benefit in reduction of sputum eosinophils on itraconazole. They did look at a few other outcomes that would be considered to be clinically relevant, such as reduction in IgE levels, in which there was a benefit of itraconazole, as well as reduced IgG versus Aspergillus fumigatus, and importantly, fewer exacerbations requiring prednisone. None of the patients in the itraconazole group had an exacerbation that required prednisone versus an average of 1.5 in the placebo group. There was also a recent study by Dr. Agrawal looking directly at comparing corticosteroids versus itraconazole in patients with newly diagnosed active ABPA who had not previously been treated. This looked at, again, a 16-week course of a total daily dose of 400 milligrams of itraconazole compared to a 4-month taper of prednisolone, starting at our typical dose of 0.5 milligrams per kilogram daily. The primary outcome in this study was a composite response to treatment at 6 weeks, and they defined this as improvement in cough and dyspnea, clearance of radiographic lesions, as well as a decline in IgE by at least 25%. And sorry, this is a little bit of a busy slide, but just to highlight a few areas. So their primary outcome was treatment response at 6 weeks, and they did find a benefit of prednisolone compared to itraconazole, with all patients in the prednisolone group achieving response to treatment versus 88% in the itraconazole group. At 3 months, this benefit did not exist anymore, with patients in both groups having 100% response. However, it should be noted that the 8 patients that are missing here in the itraconazole group actually crossed over to receive steroids in order to achieve remission, which may further show benefit of receiving steroids overall. And all of the other outcomes, including remission at 3 months, decline in FEV1, exacerbations, and the secondary outcomes, including time to exacerbation and differences in FEV1, did not note any differences between groups. There were significantly more adverse effects, as we would expect, associated with corticosteroids. Just to highlight some of the adverse effects that we can expect from itraconazole, these include fatigue, abnormal LFTs, as well as nausea. And there were significant adverse effects of steroids, including Cushingoid habitus, high blood glucose levels, acne, striae, weight gain, mood changes, and fatigue. So overall, what they concluded from this study was that glucocorticoids were more effective than itraconazole in the acute stage of ABPA, with a number needed to treat of 9. The adverse effects, however, were significantly greater in the steroid group compared to itraconazole. There were the methodologic concerns that I pointed out, particularly the patients who failed to achieve remission or failed to achieve a response in the itraconazole group, who later received steroids and achieved a response. And they conclude that itraconazole can be used as an alternative therapy, particularly as a steroid-sparing agent, as recommended by the guidelines, especially in patients who have difficulty with steroids in terms of poorly controlled diabetes or osteoporosis. A few additional things to note about the treatment of ABPA. There is postulation that there may be some benefit of using different antifungals with less toxicity, such as voriconazole, posaconazole, isovuconazole, or even just using inhaled antifungals to control the airway allergen load. Anti-IgE therapy has also been studied in very small trials of between 10 and 20 patients, and they have demonstrated some efficacy in this case as well. So this may be a future therapy to look out for ABPA, and some people are using this readily now. Likewise, anti-IL-5 is a considered strategy for controlling this condition, like mepolizumab. And allergen avoidance has not necessarily been proven to have any benefit, though it's felt to most likely be beneficial in controlling the allergen load as well, just like antifungal therapy is. There is unfortunately very limited data for cystic fibrosis patients and how to best treat this. All of the studies that I mentioned, both on corticosteroids as well as antifungals, and even some of these smaller studies looking at anti-IgE therapy, tend to almost exclusively be in asthma patients. And likewise for cystic fibrosis patients, being on steroids can be even more troublesome given their diabetes and associated osteoporosis with the condition. So in summary, ABPA is a hypersensitivity reaction and process to Aspergillus fumigatus. This can also be seen in other fungi as well. So keep the allergic bronchopulmonary mycosis in mind if a patient looks like they have ABPA based on their presentation, imaging findings, and serologic findings, except they don't necessarily meet criteria for the reaction to Aspergillus fumigatus. It tends to be a progressive and very difficult to control disease. Again, there's very limited data that supports our specific treatment modalities, but even despite treatment, a lot of patients progress to the stage 4 and 5 disease. typically occurs in asthma and cystic fibrosis patients, though there are other patients with chronic lung disease that may be affected. And one of the challenges with this disease is that the symptoms can simply be attributed to their underlying asthma or CF, which can make diagnosis a challenge. And the cornerstone of treatment is corticosteroids, but there may be a role for antifungals and other advancing therapies like anti-IgE therapy over time. And thank you all for your time, and I'll open it up to any questions. Correct, yeah. So the question was, there was one of the studies by Work in 2003. They looked at sputum eosinophils, and the question was whether or not that's a part of the diagnostic criteria. It's not involved in diagnosis. Just as a surrogate marker of airway inflammation. Yeah, serum eosinophils is one of the extra criteria that are needed 2 out of 3 and typically greater than 500, but not sputum eosinophils. There's another one in the chat box. Get that back up. So Dr. Jennings asks, has combination of steroid plus itraconazole shown to be better than steroids alone? So both of those 2 studies on itraconazole, those patients were predominantly on corticosteroids to begin with. They may have been on varying doses, and in certain cases, especially in the later study, some were just on inhaled corticosteroids, but there has not been specifically a study that controls patients on a set dose of steroids with itraconazole to showing it being better than steroid alone. Unfortunately, there was some variance between patients on how much steroid they were receiving. So that's difficult to say. Thank you.
Thank you.